மேட்டுப்பாளையமா? சரி சரி. ஐயா வணக்கம். சரி நம்ம ஸ்டார்ட் பண்ணிடலாமா சார்?
ஸ்டார்ட் பண்ணிடலாம் சார்.
ஓகே
சார் வணக்கம். சுரேஷ் பாலன் சார் வணக்கம்.
ஐயா வணக்கம் 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 வணக்கம்.
மேடம் ஜாயின் பண்றாங்களா டாக்டர் தாக்ஷாயணி?
சார் மேடம் ஜாயின் பண்றேன்னு சொன்னாங்க சார். ஆனா
வணக்கம் டாக்டர் சுரேஷ் தலைவரே வணக்கம்.
ஐயா வணக்கம். ஐயா வணக்கம். நீங்க மேட்டுப்பாளையத்துல இருக்கிறதா கேள்விப்பட்டேன். சவுண்ட் தான், ஆடியோ தான் ஏதாவது. சார் நம்ம அப்படியே ப்ரோகிராம் ஸ்டார்ட் பண்ணலாம்.
சரிங்க சார். சார் குட் ஈவினிங் எவ்ரிவன்.
Good evening.
It gives me great pleasure to be here as part of our efforts to make celebrate the World Down Syndrome Day. As you all are aware, the World Down Syndrome Day was chosen by the United Nations to increase the public awareness and also to show support for individuals living with this genetic condition. This year's theme is with us, not for us, and we are happy to be part of the group which are celebrating and increasing the awareness of Down syndrome. May now request our treasurer, Dr. Dakshayani, to say the pediatrician's prayer, please.
Thank you, sir. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்வோம். போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களுடைய வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you, Dr. Dakshayani. It gives me great pleasure that our Academy of Pediatric Sciences, IAP TNSC, is taking a lot of steps in conducting various academic programs. Now, may request our President, Sir, Dr. K.U. Suresh Balan, Professor, to say a few words on this particular day.
Thank you, Dynamic Secretary Dr. Thirumurugan. Very good evening to all. So, respected Secretary Dr. Thirumurugan, Treasurer Dr. Dakshayani, and the past President Dr. Ramesh Babu, President-elect Dr. Balashankar, and the Central IAP EP member and the Chairperson for today, Dr. Aram Chandil Sir, and Dr. Somasundaram, Dr. Jalil Ahmad, and the eminent faculties for today, Dr. Pradeep Kumar from Kowe Medical Center, Coimbatore, who is a specialist in genetics, and Dr. Anuradha, who is said to join.
She joins, sir.
Yeah. So I welcome Dr. Anuradha also. She is my MBBS batchmate from MMC, and she is going to talk on the prevention of genetic disorders with a special focus on Down syndrome. And we are very happy that IAP TNSC has taken up this day, World Down Syndrome Day, as a concise treatise on Down syndrome program. It's an academic program. I appreciate the efforts taken by Dr. Thirumurugan, Dr. Sendil Sir, Dr. Dakshayani, and all the persons concerned to observe this day as a very important day, along with the World Forum, that is the United Nations, which has announced this day as a day for disabled children, especially on Down syndrome. They have selected this day 21/3 on every year because 21 is trisomy 21. To remember that as trisomy 21, they have selected as 21. And it's a global awareness day, officially announced and observed by the United Nations since 2012. That is, they have observed that people with Down syndrome are not allowed, their voices are not heard, they are not affording quality education, they are not affording good health care, they are not afforded the chance to work and earn their money, and are not allowed to make decisions about their own life. We have seen Down syndrome ever since our undergraduate and postgraduate days. We see them as only a clinical case. We never thought their background, or we never felt what is their challenges they are facing in their future life. We even see Down syndrome people who are occupied as a telephone operator or some petty jobs, even in medical colleges, we see them. But international agencies like United Nations have taken this as a challenge, and they want us to raise a global voice, advocate for the rights and inclusion and well-being of people with Down syndrome. That is the focus today. And so I am very much pleased to be a part of this program as an academic program. And we are yet to see what other options are available as an organization to help these children or these adolescents with Down syndrome as the larger part. That is the most important thing which we have to focus on. And I am very happy to welcome once again our eminent speakers, Dr. Pradeep Kumar, Dr. Somasundaram, and Dr. Anuradha, who are going to deliberate on the topic. With this, I hope every one of us will work as a team, raise our voice as advocates for children. Thank you very much, sir, for this opportunity.
Thank you very much, sir. So I'm sure today is going to be a great treatise on Down syndrome. And we planned it in such a way that's going to be a short and a sweet program. So may I now request our chairperson, Dr. Aram Sendil sir, past president of IAP TNSC, to chair the session, please. Over to Dr. Aram Sendil sir.
அனைவருக்கும் இனிய மாலை வணக்கம். Good evening to one and all. Respected President Dr. Suresh, Secretary, Treasurer of IAP Tamil Nadu State Chapter, who are doing a wonderful job in commemorating all the days, special days, which have been allotted, and they are doing a wonderful job in commemorating these days because each and every child counts. So Down syndrome, as Dr. Suresh had said, we have been seeing them all these years, but are we really making them realize their own potential? So that is how we have to see them as children who are really with a disability, but they also have a potential to live in this world. And so we have got eminent speakers today, Dr. Pradeep from Coimbatore, Dr. Somasundaram, our expert from Chennai, and Dr. Anuradha from ICH. So all these three are here to give us a wonderful deliberation. We know that Down syndrome can be diagnosed antenatally, and there is a lot of decrease of incidence nowadays, but still these children are also our children. We have to take them. Let us go in deep and know about them from our experts. Thanks for the opportunity for today's session, and the concise treatise for Down syndrome will be given by our stalwarts. Thank you for the opportunity.
Thank you, sir. May I now request you to introduce the first speaker, Dr. Pradeep Kumar. I think sir is having some problem with his network, so let me just have the opportunity of introducing Dr. Pradeep Kumar. Dr. Pradeep is currently working as a head of medical genetics at KMCH Hospital. He has done his MD Pediatrics and DCH and DNB. And also, he has done his fellowship in clinical genetics. I think those who are visiting YouTube will really know how active he is. He's one of the very active proponents of spreading the knowledge about genetic disorders. And we are very happy to have him. He is associated with a lot of parental organizations for genetic care. And he has plenty of awards as he has achieved. He has won the Balagopal Raju Award for the best scientific paper, Dr. BRS Award, Dr. K.R. Lahiri Award, and many more. So without wasting much time, and he has got, of course, got a lot of publications. So without wasting much time, may I request Dr. Pradeep to take over the session, please. Thank you, Dr. Pradeep.
Thank you so much, sir. Thanks a lot, IAP TNSC, for this wonderful opportunity. Special thanks to our president and the chairperson who have expressed their. Sir, if I am breaking, please let me know, sir. Or my video is not clear, please let me know, sir.
Yeah.
Is it okay, sir?
Yeah, it's okay. Fine. You can share the slides.
Sure, sir. Yes, sir. So thanks a lot, and thanks for sharing our own thoughts, sir. As caretakers of rare diseases, whatever Suresh sir and Sendil sir has shared is what we also feel. Every child counts, and we have to do as IAP, as a big unit. We have to do something for these children. And from my heart, the bottom of my heart, I thank for this initiation to do all these things for particularly rare diseases. As always, IAP is willing to do. Thanks for the entire team, academic team, and the senior pediatricians and my friends. Without wasting much time, I will be presenting on antenatal aneuploidy screening. That is, we are talking about once the baby is born and getting the diagnosis, but how to prevent a baby being born with the Down syndrome. So the aneuploidy screening is mostly focused towards Down syndrome, though it can detect other aneuploidies also. So what are all the conditions screened during antenatal period? The common one is trisomy 21. Of course, trisomy 18 and 13 also will be in the list whenever we do screening tests. And parameters considered are maternal age, maternal serum biochemistry, and fetal ultrasonography. All these findings put together, we can find out the high risk or low risk category in these mothers. Why aneuploidy screening is needed? Why should we diagnose these problems? So the Down syndrome particularly has health implications, quality of life implications, and social implications. The live birth incidence is considered to be 1 in 600 and odd, 600 to 700 in various studies. And there are so many issues with them which makes their life little difficult, and for the family also to take care of these children, it will be very difficult. They may have developmental delay, behavioral problems, learning disabilities, obstructive sleep apnea, hearing loss, obesity, heart disease, particularly 30 to 40% may be life-threatening, and gastrointestinal problems may need surgery also. Alzheimer's disease and leukemia are dreaded complications for these babies. Because of that, these screening methods are popularly used to avoid babies being born with trisomy 21. And little about the genetics. Of course, madam is going to talk about genetics in detail, but as we all know, pure trisomy 21, 1, 2, 3 at 21st locus is the commonest one, 95%. It belongs to the pure trisomy 21 category. There are other categories like translocations that constitutes about 4%, and mosaic Down syndrome constitutes about 1%. Why should we do karyotyping for a baby who is born with Down syndrome? Of course, we know phenotypically this baby has all the features, but most importantly, to prevent recurrence, to know the recurrences, we need the karyotyping. If it is a non-disjunction type, pure trisomy 21, recurrence is low, less than 1%. Mosaic type, again, very low recurrence. But translocation types, the recurrence risk varies. If the mother or father is a carrier of translocation, the recurrence risk may go up to 10 to 15% or even 100% in 21 over 21 carriers. So because of this, we need to do a karyotyping for babies with Down syndrome. But again, if the baby is born and baby's karyotyping is done, translocation is found out, do a parental karyotyping. If parental karyotyping is normal, then the translocation has happened due to accident. It is de novo, sporadic event. So don't worry about next pregnancy. If it is pure trisomy also, there is no need to worry. If in case parent is a carrier of a translocation, then the recurrence may be significant. We may need to do amniocentesis or CVS in the next pregnancies to know the recurrence. This is little about the genetics part. Of course, it will be dealt in detail later. So age risk related risk for trisomy 21, we all know elderly mothers are at high risk for getting a baby with Down syndrome. Of course, this is not enough. With the age alone, can we do a screening? Can we take that alone as a screening method? Is not enough, because the detection rate is only 30%. It can only detect 30% of children with Down syndrome. So age alone is not enough for us. Do we need to screen all pregnant women? Because age is the criteria, we know elderly women. But again, we need to screen all the pregnant women because the fertility rate is less in the younger women. And because of that, the incidence of babies with Down syndrome is high in maternal age is less than 35. So young mothers, highly fertile, their pregnancy rate is higher. Because of that, the incidence of Down syndrome is higher in younger mothers. So, but again, 70% occurs in less than 35 years because of high fertility rate. And most importantly, this happens as a genotypic surprise. Babies will be born as surprise. Once the baby is born only, we will know, because most of the time it will remain silent because ultrasound markers will not be picked up. The concept of screening, any screening test, it should be available easily, and it should be less invasive. A diagnostic test which gives 100% result is fetal karyotyping, but we cannot offer the same to the fetal karyotyping by chorionic villus sampling or amniocentesis for this whole population, which is a huge population. So we can screen the population, select them, and then do the confirmatory testing like CVS or amniocentesis. The various screening tests are available. The detection rates varies between 65 to even 99% for trisomy 21. And most importantly, these are not diagnostic. These are just screening methods. It can have overlap between affected and unaffected, considering the false positive rates. So false positives and negatives are inherent in any screening method. An ideal screening method should be easy to implement, and it is of low cost so that everybody can take it, and it should have a high detection rate for the particular disease concern, or low false positive rate should be there and yearly, and it should be relatively safe. All these things is available, and it can be done from the maternal blood in aneuploidy screening. That is why this screening is a big hit. It has been done everywhere, widespread available. So filtering method, you screen a population, pick up only the people who are at high risk, and then do an invasive test and find out the abnormality. So it is just like filtering from the population, a higher risk group, and this higher risk group will go in for the invasive procedure. This slide is very, very important because this explains the detection rate for various screening methods used popularly. So in the first trimester, nuchal translucency by ultrasound, this detects about 70%. The detection rate is 70%. Of course, it misses 30%. And first trimester blood screen plus nuchal thickness, that is beta HCG, free beta HCG, and PAPA, along with NT, the whole combined screening test. This gives about 85% detection rate, and triple screening done in the second trimester only 70%, almost equal to NT scans, and quadruple screening 71 to 80%, little better than the triple screening. So integrated screening, that is doing first trimester blood screening, NT, then second trimester blood screening, may go up to 95 to 96%. But again, bringing the patient again and again and follow-up is very, very difficult. They may lose the follow-up. We may not complete this. Serum integrated, again, first trimester and second trimester has a high detection rate, but these are practically not feasible. So practically very easily available at a lesser cost. The popular one is first trimester blood screening and NT ultrasound. This is called combined first trimester screening. It can detect 85% of the babies with Down syndrome. If in case, if the mother is high risk or the patient wants a better testing option, then there is another option called non-invasive prenatal screening. It detects up to 99% of trisomy 21. So this can be offered to high-risk mothers more than 35 years of age, previous babies having Down syndrome, or who are very anxious, who wants the best test available. Then you can suggest this test for these families. 99% is the detection rate. Next best test will be NT-FTS, that detects about 85%. So first trimester markers, PAPA and free beta HCG, along with we can take nuchal translucency, which is a powerful marker for detecting Down syndrome. And nuchal thickness and first trimester screening can be used. 85% is the nuchal thickness, along with FTS gives 85% detection rate. So second trimester screening, it can be done between 15 to 19 weeks of gestation, ideally 16 to 18 weeks, and alpha fetoprotein, beta HCG, and conjugated estradiol inhibin. This is quadruple testing. That is better than your regular triple load. So in case if they missed a first trimester screening in second trimester, whether triple or quadruple, we have to go ahead with the quadruple testing than the triple testing because the detection rate is better. Cell-free DNA, non-invasive prenatal screening, how is this done? It actually filters the fetal cells from the mother, and then it can be used for screening Down syndrome. So 10 weeks, from 10 weeks, we are eligible. The patient will be eligible to do this, and the amount of fetal cells will increase over the gestation. But again, we prefer to do that between 10 to 20 weeks, so that if in case if it is positive, to do a confirmatory test by amniocentesis will be feasible only at 20 weeks, because later the pregnancy may advance. The PCPNDT says only 24 weeks is the cutoff for termination of pregnancy if it is detected. So anytime you can do, but to detect this and do something, 10 to 20 weeks, it will be a better timing. So 10 to 16 will be a better timing. We get results in 2 to 3 weeks. Next, if needed, a confirmatory testing can be done. Detection rate is 99% for T21. Lower detection rate for T18 and T13. Of course, T18, T13, trisomy 18 and 13, we have ultrasound markers also. So low false positive rate in high-risk women. So, if fetal fraction is more than 10, it is more effective. But again, now the labs are having their own validation protocol. They give results even with lesser fetal fraction. Results do not always represent fetal DNA. There may be contamination of mother's DNA, so confined placental mosaicism. So because of all these reasons, you cannot take this as a confirmatory test, though it is 99%. No irrevocable obstetrical division, no final decision should be made with a positive non-invasive prenatal screening result without confirmatory. So after cell-free DNA, if it is high risk, do a confirmatory testing by amniocentesis and then only decide whether to continue or not. So fetal fraction minimum of 8%, but again, labs have come down. Not a confirmatory test. Polyploidies cannot be screened. Placental mosaicism can cause analysis problems. Fetal fraction is lower with increasing maternal BMI. So it cannot pinpoint the exact fetus. So aneuploidy screening in twin pregnancy may not be useful. Cost-wise, it is relatively of higher cost. 10 to 15% is 15,000 is the range compared to NTFTS, which is around 2,500. So other ways of detection, other clues about Down syndrome screening or structural changes, these are called soft markers. These are not major abnormalities, anomalies. Major anomalies like AVSD can be picked up, but soft markers are some clues which will give us a clue that something wrong is happening there. So may present in normal fetus as normal variant also. So we have to keep in mind whatever soft markers we see, these are just markers, clues. They are not diagnostic. They are not going to affect that organ. But it can be thought to be more commonly found in fetus with chromosomal aneuploidies. So varying sensitivity for detecting aneuploidies may be from 50 to 78%. And in isolation, they have no effects. But if in combination, multiplicity increases the risk of aneuploidies. So some markers, even isolated, that is delayed nasal bone ossification, more than 16 weeks of gestation, we take it very significantly. And nuchal fold thickness, if it is very high, have significant association. These are isolated markers which have high risk for aneuploidies. So difficulty is in interpretation and communication to the parents, anxiety and stress. Simple nasal bone, which is unossified, creates so much of anxiety. In spite of us telling them that chromosome is normal, nasal bone will get ossified later, they'll be worried about the nose, whether the nose will be normal later. So all these small things, they may not understand, but it will create anxiety and stress. We have to handle all these things with proper consultation and counseling. Most importantly, don't make hasty decision based on these. Think twice, give the benefit of doubt always to the fetus. Always stand for the fetus, talk, and then make them decide about it. So considering all these sonographic markers, the detection rate, likelihood ratio for aneuploidy are like this. So nuchal fold, it carries high likelihood, 99.88%, and then major defects 5.2, short humerus 4.1. So these are the abnormalities which has isolated marker likelihood ratios. And most importantly, you can see here increased nuchal fold, your ventriculomegaly, your ARSA, absent or hypoplastic nasal bone. These carries higher likelihood ratios for aneuploidies. So based on all these things, the background risk of the aneuploidy screening, along with it, if you get some ultrasonic markers, risk reinterpretation can be done. This can be done with various softwares from the labs, or we ourselves can do it. Background risk divided by likelihood ratio of soft markers, isolated, multiple, likelihood ratio can be multiplied. That will be the denominator. Based on that, we can reclassify based on the ultrasonic markers. The low risk can go high risk because of ultrasound markers. Low risk in your serum markers can go high risk later if the ultrasonic markers are found. So online calculators are available with so that can be used for patients to do the reinterpretation. So soft marker concepts are detection of one marker, look for other markers also, particularly hypoplastic nasal bone, nuchal fold, ARSA, aberrant right subclavian artery, ventriculomegaly, where strong isolated markers, and short humerus echogenic bubble have modest accuracy. Isolated choroid plexus cyst, intracardiac echogenic focus, pilectasis, all these are low risk category. All these belongs to low risk category. Multiple markers in any of these groups are considered significant. No markers on scan helps to modify the risk. Again, negatively, we can have the likelihood ratio. It will reduce the possibility of aneuploidy if it is not found also. So multiple pregnancies, there are limited data to compare the singleton pregnancies, particularly with serum biochemical markers. So establishing chorionicity and then doing risk assessment based on ultrasound is the ideal way, because most of the serum biochemistry we cannot differentiate in children with in the pregnancies with twins or polyploidies. Even NIPT cannot be completely reliable in case of twin pregnancies. Better to go ahead with only with the ultrasonic markers. In short, if in case mother is at high risk, more than 35 years, you can offer them non-invasive prenatal screening. If it is negative, continue with the pregnancy. If in case the mother is in low risk category, less than 35 years, a primary mother, no significant history in the family, regular first trimester screening NT-FTS will do, but we have to tell them it detects only 85%. Most of the time parents will come to us saying the baby is born with Down syndrome, but we did all the screening tests. Then we will retrospectively explain to them that it will only detect 85%. So first trimester screening 85%, that is enough for low risk mothers. If it is positive, then giving them the option of confirmatory diagnosis by chorionic villus sampling or amniocentesis can be given. If in case it is negative, if the family don't want to go ahead with invasive testing, we can offer NIPS for the positive groups because it detects 99%. Again, if it is positive, they can take up confirmatory diagnosis. If it is negative in a low risk mother, NT-FTS, first time screening is negative, low risk mother, we can reassure them and follow up only by ultrasound. So what is practical in our country? Maternal age alone is insufficient because only 30% is the detection rate. And first trimester screening is cost effective, superior to triple and quadruple screening, and relatively cheaper or can be offered to low risk mothers. And quadruple screening up to 80%. So if in case somebody misses first trimester and in low risk category, maybe quadruple should be given rather than triple. Second trimester ultrasound can be useful adjunct to other protocols. It increases the risk or it can decreases the risk also. So best screening test available for trisomy 21 is non-invasive prenatal screening. The detection rate is 99% and it can be offered to high risk or affordable patients. And most important thing is all that screen positive are not babies with Down syndrome. If the risk is 1 in 50, remember there is a chance that there will be 49 normal babies inside and only one baby will be affected. The risk percentage is only 2% if it is 1 in 50. 98% babies can be normal. Previously, parents go terminate seeing the high risk also. Nowadays, awareness has come up. So thank you so much. If there are any questions, I'll be happy to answer.
Thank you very much, Dr. Pradeep.
Thank you, sir.
Like your talk was very, I mean, it's a bit complicated, but very clear, giving the message about antenatal production.
Thank you, sir.
As there are no questions, may I now request our developmental pediatrician, Dr. Somasundaram, former secretary of IAP TNSC, to talk a little bit about the follow-up of a child with Down syndrome. I think given the time, we are just falling behind schedule. I'm not going to talk. Everybody knows about Dr. So I'm not going to introduce him, except that he is the past secretary and future president of IAP TNSC. So thank you very much.
Thank you, Thiru, for your nice words. And respected seniors, Dr. Suresh Balan sir, Dr. Jalil, and all the respected seniors here. And my dear friends, Daksh, Pradeep, and all the delegates who have joined on this forum. And thank you, IAP TNSC, for organizing a wonderful CME program to commemorate the World's Down Syndrome Day, and inviting me also as one of the speaker among two genetic stalwarts here, Dr. Pradeep and Dr. Anuradha. And I will be a basic pediatric, I'll give you a basic pediatrician view on what you do when you encounter, because people are there to find out your antenatal issues and prevention issues and those things. But as a pediatrician, you will be also facing, and I am also still following up few children in the developmental aspect also, and in the general pediatric aspect also. So you should know what systems and what concentration which to be followed up, what to be screened when you have a child with the Down syndrome, when they come up with you. You can't say that you should always go to the specialist for a Down syndrome, because in your place of practice, you will be the specialist to follow these children with the Down syndrome. This is the code, and I have written a chapter to the IAP Handbook of Developmental Pediatrics on Down syndrome. And that was done about 3-4 years ago, and just I was going through that, and I found this code which I have written there. I am not a Downs. Don't call me Downs. I am a person with Down syndrome. Down syndrome is just nothing I have, not who I am. So there is nothing that people with Down syndrome can't do. And the people on this list only serve to prove that they have broken barriers, shattered the stereotypes, not only through their accomplishments, but through their advocacy as well. As we see in the media that many people are coming up better, people with the Down syndrome. The peanut butter falcon star, Zach Goodsagan, made history at the 92nd annual Oscars as the first presenter with the Down syndrome. He was the first presenter to give the Oscar in the Down syndrome, with a Down syndrome thing. Actor Pablo Pineda was the first European with the Down syndrome to get a university degree. Indian Surjit Desai plays 7 instruments and is the first musician with the Down syndrome play at the Carnegie Hall. Chelsea Werner is a champion gymnast and a model with the Down syndrome. So you can't differentiate that she has the basic features of Down syndrome and so thing. So we have to, when you have a kid or a child with Down syndrome, these are the 4 aspects of life we have to concentrate on. First is the health. So what are the health parameters? Am I looking into for the hematological things? I am looking into for the neurological things and those things. And am I looking into for the education? What education should I fit for this child? What employment will suit this child? And how am I going to integrate the child and the life in the community? So we are always approaching any developmental or any child with a developmental issue in the biopsychosocial approach. Bio means we all know this is the physiological pathology. We all know that this child has got a congenital heart disease, this child has got a short stature, this child has got a different facial profile. Psycho means what will be the thoughts, emotions, and behaviors, such as psychological distress, belief, and current coping methods, what they have. And what is the social impact on this child? That's the cultural factors, work issues, family circumstances, social environment. So all these things will group into the biopsychosocial approach of a child with a Down syndrome, or may it be any developmental problem. So as the previous speaker has told, the management has evolved from a medical model. We thought Down syndrome, okay, we have to treat the child as a medical issue. No, it's moved on from a medical model to a social model. Now we are going to integrate these children into the society. And now it has become a rights model. So what rights a child with a Down syndrome are having? So this is the way the society is moving on with in handling these children with the Down syndrome. So in the next 10 minutes, we will see about 8 to 10 systems where we are going to concentrate. Growth. The growth potential, as we all know, is less compared to a child, compared to children with a normal karyotype. So comparing, so leave alone the weight may be obese, may not be obese, but always the height and head circumference fall. They are always affected. The final height is less by 2 to 3 standard deviation in comparison with that of the individuals of the same sex. Head circumference is also less by almost 2 standard deviations. So when you are always encountering a child with Down syndrome, always use the Down syndrome growth charts, which is available in the CDC website. Until a chart is available in the Indian subcontinent for a child with Down syndrome separately, we are supposed to use this growth chart for children with Down syndrome, which is available from the CDC website, and they are standardized for children with Down syndrome. So to summarize, a chart with the Down syndrome, specific for Down syndrome, should be used, which is available from CDC, and the height and the head circumference always are below the 2 standard deviation. So this is regarding the growth of these children. Coming to the weight, they tend to be obese, especially during the adolescent period. What are the likely determinants of obesity in these children? That is, the leptin is increased. They have a decreased resting energy expenditure because they move less likely. So they have a resting energy expenditure. Many comorbidities are there which can increase the weight, like a hypothyroidism. Depression will increase their food intake. Unfavorable diet and low physical activity. So these are the determinants for obesity in these children. As we can see that most of these children with Down syndrome are obese. Prevention, management, similar to that for all other children, appropriate exercise programs and dietary modification. So monitor the growth, monitor the weight. If the child is in the obese level, advise them as a primary pediatrician for these children, advise them on the appropriate exercise program and dietary management. Development. Motor milestones always are in the lower side because of muscle hypotonia, brain stimulation, and those things. Language, yes. Specific delay in language to use the spoken language means that the expressive language is bit delayed relative to their non-verbal understanding. Their receptive language is very good, but their expressive language is delayed. They are always a social functioning is good. They are always smiling at all the faces. So social functioning is good, but social understanding is poor. They don't know what to do in the various social situations. So the social understanding is poor in these children, and they have a less IQ compared to a child of a normal karyotype. And some degree of intellectual disability is always there, making this the most frequent genetic cause of intellectual disability. As you can see, this is a chart which I have added in that chapter 2, and this is the range for children with Down syndrome and the typical range. If you ask sit alone, it is between 5 to 9 months. The max is 9 months, but a child with Down syndrome has a range of 6 to 30 months till you can take up to 30 months. Crawling is 8 to 22 months. Standing is up to 3 years. It can take. Walk alone, it can take up to 4 years. Language, first word can take. Language is very, very delayed in children with Down syndrome comparing the other domains. 2-word phrases is you can up to go to 2 to 7 years. Social, responsive smile, finger feeding, drink from the cup, using the spoon. Everything has got a range which is well later than a normal typical range child. So considering the development, motor development is delayed. Intellectual disability can be there. Spoken language is delayed, but a receptive language is good, and they are very good in gestures and imitations. Means that non-verbal functioning and non-verbal communication are better developed in these children than the other children. So that's the thing about development. Coming to the cardiac defects, what am I going to look for and what am I going to screen? And is there a difference between a children with a normal karyotype and a Down syndrome karyotype? So as you all know, the most common and the leading cause from your undergraduate days, we have seen that cardiac defects are common and the cause for morbidity and mortality. Incidence is up to 50%. Most common is atrioventricular septal defect followed by VSD. 2 points I want to mention here. Because of the high prevalence of CHD, recommended that all patients get an echocardium at the earliest, at least within the first 6 weeks of life. Then the second point is that there should not be a delay in the correction of the large shunt lesions because of the high propensity for the rapid development of pulmonary vascular disease compared to the normal karyotypic children. So we are all supposed to do a screening echo in all children within the first 6 weeks of life, and the shunting, the procedures, the corrective procedures should not be delayed if there is a need for the corrective procedure. This is regarding the cardiac issues. Thyroid. Thyroid, invariably, many children will land up having hypothyroidism. So you are supposed to screen these children frequently for thyroid issues. Can be a subclinical thyroidism or a congenital hypothyroidism. So they can be congenital or acquired at any time. So only important thing that don't screen these children only at neonatal period and then leave that, oh, this child doesn't have a thyroid issue. You are supposed to repeat the screening every 6 months once, repeat at the age of 1 year. Every year you have to follow up these children and do a thyroid screening. They can be a subclinical hypothyroidism, which is most common, characterized by elevated thyroid stimulant, TSH alone, and the normal free thyroxine, which we all know. Congenital hypothyroidism, 20 to 30 times more common in neonates with Down syndrome. Most are due to thyroid hypoplasia. Congenital hypothyroidism is not always picked up in the newborn screening. Hence, repeat screening at 6 months is recommended. Screening has to be repeated at the age of 1 year and every year thereafter. So considering the thyroid gland, don't leave these children only with a neonatal screening. Can be a subclinical hypothyroidism, which can be picked up by a TSH alone, and treat only when the TSH remains persistently about 10, which is according to the general population about 10 microunits per ml. Coming to the hearing issues. Hearing issues, 50% of people with the Down syndrome have hearing impairment. Earlier part, they can have conductive hearing loss. Later part, they can land up with sensory neural hearing loss as age advances. The large adenoids, the small nasopharynx, the facial profile, they have a different facial profile, right? So the large adenoids, small nasopharynx, impaired swallowing, and now narrow horizontal aestuation tubes are contributory for ear problems. So once the ear problems can be an otitis media or something like, which can lead on to hearing, conductive hearing loss. So neonatal screening is recommended, followed by a full audiological assessment between 6 to 10 months. So do a OAE testing at the newborn period before 28 days. Do a full audiological assessment, preferably with BIRA at 6 months of age. Review at 18 months, followed by every year till 5 years of age. That is the recommendation for hearing screening for these children. Wax accumulation, it is found to be more in these children. That also can lead on to conduction deficit. So regular dewaxing is recommended. If these children have an otitis media with effusion, a Grome incision is advisable with adenoidectomy in case of recurrent otitis media. So I would again and again reinforce that these children are prone for hearing losses. So you have to follow up these children with a screening every year till 5 years of age, and wax removal should be advised for these children. Ophthalmic problems. Seen many children with Down syndrome wearing goggles because refractive error occur at an early age also, and also they are more common, 10 times more common than the general population, and it occurs very early also. 54% of children with Down syndrome require a prescription spectacles in the preschool. Also, other issues are also common. That is the blepharitis, dryness of the can be because of the dryness. Congenital cataract, congenital glaucoma are also very, very common. So it's better to screen these children in the newborn period at 4 to 6 weeks to exclude congenital glaucoma, congenital cataract, and eye abnormalities. And for refractive error, every year the children with Down syndrome to be done an ophthalmic examination. So this is regarding the ophthalmic problems. Hematological issues. This is the very, very specific issue to Down syndrome. That is called as transient abnormal myelopoiesis, TAM, previously known as the transient myeloproliferative disorder, quite specific Down syndrome, which is defined as the detection of blood cells in younger than 3-month-old babies with Down syndrome. So if you are doing an CBC and you are finding blast cells in a child less than 3 months, you can think that this can be a transient abnormal myelopoiesis characterized by hepatosplenomegaly, skin rash, pericardial and pleural effusion, extreme leukocytosis, and coagulopathy. The peculiar feature is that bone marrow examination is not useful for the diagnosis. Usually when there is the myeloproliferative problem, we go for a bone marrow. But here, the blast cells are formed from the fetal liver. So the bone marrow is not useful. The second thing is that patients with Down syndrome are 10 times more at risk for developing leukemia. So you are supposed to do an annual peripheral smear and a complete examination, which should be repeated yearly till 5 years. So what are the things which we have to repeat? A thyroid screening has to be done. A cardiac screening has to be done at birth. An ophthalmic screening has to be done every year for refractive error. A hearing screening has to be done. A complete blood count and a peripheral smear examination should be done yearly till 5 years of age. Gastrointestinal, we are not going to screen them, but if any issues are there in the anomaly scan, we are going to follow up these children. Structural abnormalities are also very common. Functional disorders are also very common. Structural anomalies like esophageal atresia, duodenal atresia, jejunal atresia, annular pancreas, anorectal anomaly, Hirschsprung's disease are very, very common. Considering the functional disorders, feeding difficulty is very common. GER is very common. Constipation is common. Celiac disease is very, very common. So you have to think about doing a gluten antibody or a gluten-free diet for these children. So gastrointestinal. Renal and genitourinary involvement, CACUT, all these congenital anomalies like glomerulonephritis, renal agency, cyst, ectopic kidneys, abnormality of the urinary tract, hydroureter, posterior urethral wall, undescended testes, everything is very, very common. The other thing is that they take longer to develop the sphincter control. So dry by day and dry by night can be longer in these children to a greater extent. Important point is the risk of testicular tumor is 6 to 50 times higher than in the general population. So things to be followed up. Recommendation is postnatal follow-up need to be done to rule out renal problems if anomaly scan has showed any abnormality. Yearly testicular examination should be done in boys to find out any variation in the size of the testes to detect testicular tumors at the earliest. So that is the recommendation. So palpate the testes in these children. Musculoskeletal issues. Musculoskeletal problems are common due to central hypotonia. The ligaments are lax and excessive joint mobility. They may have musculoskeletal problem like subluxation of a joint, slipped upper femoral epiphysis, Perthes disease, pes planus, hallux valgus, CTEV. There are a lot. And peculiar thing is the atlantoaxial dislocation, which is common, more common than in the general population. The point when this atlantoaxial dislocation issue comes when you are planning for a surgery and planning for an intubation. So you have to be very careful when you are, you should screen these children whether they are prone for atlantoaxial dislocation before planning for a surgery and going in for anesthesia. Dermatological manifestation, seborrheic dermatitis, dry skin, acanthosis nigricans, alopecia areata. I have 2 kids who are on developmental follow-up with the Down syndrome having alopecia areata, but they don't have any other immunological abnormality, just alopecia areata alone. And they are prone for accelerated aging, that is graying, thinning of scars, skin atrophy, wrinkles and lentiginous. They are prone for early aging, accelerated aging. Oral health issue. Large and fissured tongue with small oral cavity, malalignment, dental agencies are very common. Enamel hypoplasia, delayed dentition compared to the general population. Dental caries, they are prone for dental caries and periodontal disease. So what should be done? First dental visit should be within 6 months of the first tooth eruption. So always have a tie-up with your dental doctor if you are following up a child with a Down syndrome. So every yearly you should follow up these children whether they are developing dental caries or something like. Brushing should be done twice daily with a soft toothbrush and fluoride toothpaste to avoid dental caries because they are prone for dental anomalies. Puberty, sexuality and menstrual cycles. The peculiar thing that they have gonadal dysfunction. There may be abnormalities of LH and FSH. Even then, puberty occurs on time and progresses at a typical rate as in other children. So that is the part because these children need special attention for that. In fact, all individuals with have Down syndrome also have the intimacy needs and sexual feelings as in other children, and they should be counseled accordingly. So a psychologist, counselor should be there. So a girl should be educated about menstruation in advance. So this is the thing about puberty and thing. So whatever has been told has been summarized in this chart. What am I going to follow up? The growth, the weight, height, and head circumference, year evaluation, OAE in the first month of life, follow up with the BERA, later stages if there is a need for tympanometry, every year it has to be done. Eye evaluation, I will do a cataract or a congenital glaucoma evaluation at the birth, and the refractive error follow-up every year till 5 years of age, and later also till 12 years of age, and later every 3 years about 12 years of age. Thyroid profile, I will look for in the neonatal period, but that is not sufficient. So I will do it 6 months and 12 months, and every year I will be following it up. Heart, at the initial contact, preferably before 6 weeks, I will do an ECG and an echo. Sleep studies are recommended if the baby is having a sleep issues. Blood, CBC has to be done because they are prone for leukemia, and in the first 3 months for the TAM. So first month it has to be done, and annually till 12 years of age. So finally, for the management or the follow-up of these children, a basic primary pediatrician, if he is vigilant enough of all these issues, can be a good caretaker for these children with Down syndrome, or a specialized team is needed to follow up these children of all specialties should be included. And these children, since they have a low intellectual disability, intellectual functioning, these children are to be advised and inclusive schooling, where they will be, and probably the LKG or UKG has to be started later, probably by 6 to 7 years of age. I have not put up in the slides, but 6 to 7 years of age, because then only they will be able to matching up with the other peers, and an inclusive education is better in these children. And a multidisciplinary team is always needed to manage any complications, or any referral has to be done to the specialist to follow up these children. Thank you for this opportunity, and thank you for the patient hearing.
Thank you, Dr. Somsundaram. There are a couple of questions I think we will take up right to Dr. Pradeep Kumar. Probably those can be addressed when Madam Anuradha Madam is discussing, so we can discuss it right at the end. So may I now request Dr. Dakshani, our treasurer, to introduce Anuradha Madam, please.
Thank you, sir. Gives me immense pleasure to introduce my speaker, Professor Dr. Anuradha. She's now a professor of pediatrics at the Institute of Child Health, and she's an alumnus of Madras Medical College. And even as a pediatrician, her special interest in rare diseases made her pursue her PhD in genetics, and now she heads the Department of Medical Genetics at the Institute of Child Health. She's a passionate teacher and an unassuming person. And thank you so much, ma'am, for accepting the offer. And over to her talk on prevention of rare diseases with pertinence to Downs.
Thank you, madam. Am I audible, madam?
Ma'am, you're audible, ma'am, and your slides are visible.
Good evening, one and all. I would like to first thank the organizers and Dr. Suresh Palan and Dr. Darshani madam for giving me this opportunity. And this is the first time I'm talking in an IAP forum. So I will just, most of the queries have been answered by previous speakers. So mine will be a lighter topic of that. So what are the frequently asked questions whenever a family with Down syndrome come? So what is Down syndrome? Is there a cure? Does trisomy 21 run in families? What is the possibility of my next child being affected? Should we undergo a genetic testing? So these are the common questions asked by the patients when they come to us. Next slide. So there are certain myths regarding Down syndrome. So myth 1. This is a myth which is present among the patients. So my baby won't have Down syndrome because I'm young, I'm healthy, and I have a healthy lifestyle. But what is the real fact? Any pregnant person of any age can have a baby with Down syndrome, regardless of her age, health, and healthy behaviors. So going to myth 2, my baby won't have Down syndrome because no one in my family or the father of the baby's family have Downs. But the fact is, Down syndrome usually does not run in families, except when it's a translocation. Myth 3. I should not have a test done for Downs unless I would like to terminate the pregnancy or which is detected early. But the fact is, many people who would not like to terminate should have a screening test. So that they will know about the baby before birth, so that they can plan the delivery and newborn care. Myth 4. My friend told me that if I have a screening test, it will come back positive, and most of the time the result is positive. The fact is, most people who have a negative result have a lower risk of having a child with Downs. Previous. Okay. Now, going into the queries. Is maternal age the reason for getting Downs? So briefly, I will talk about the meiosis and meiotic non-disjunction. Since meiotic non-disjunction is the commonest cause for getting a trisomy. So this is a picture showing the various steps of meiosis 1 and 2. So in the first picture, when there is in a normal meiosis, there is a separation of pair of homologous chromosomes equally. And when it is fertilized by the sperm, the zygote will have 46 chromosomes. But when there is a non-disjunction, either in meiosis 1 or in meiosis 2, there is an unequal separation of these homologous chromosomes. So when this is fertilized by a sperm, there is either a trisomy with an extra chromosome, or there can be a monosomy with a less chromosome. This is how you get a child with a Down syndrome who's having an extra chromosome, or a monosomy in case of a Turner syndrome. So next is, what is Robertsonian translocation? As the other commonest cause for Down syndrome is a translocation. So what do you mean by translocation? Translocation is a transfer of a genetic material between two homologous chromosomes, which is said to be balanced. So whenever there's a translocation occurring between acrocentric chromosomes, it is called as a Robertsonian translocation. So normally 13, 14, 15, and 21, 22 are said to be acrocentric chromosomes because they do not have a P-arm. They do not have a P-arm. So when there is a pairing between this carrier who's having a Robertsonian translocation with a normal chromosome, you get a child with Down syndrome. So what are the common cytogenic aberrations that can occur in a child with Down syndrome? The first, as we told, the first picture shows the trisomy 21, where there's an extra 21 chromosome, which is the most commonest type. The next common is the mosaicism, where you get the same person will have a karyotype showing two different cell lines. One will be a normal cell line. The other cell line will have an extra 21 chromosome. So depending upon the number of extra 21 chromosomes, the severity can be accounted. The third most common type is the familial Down syndrome, where there is a Robertsonian translocation or a fusion, centric fusion between the Q arms. So this is when there is a Robertsonian translocation, the chances of a hereditary transmission does occur. So every child has a chance of getting a child to get Downs. So summarizing this, 80% of Down's children will have a trisomy 21 or a mosaicism, and 1/3 will have a translocation, which is mostly hereditary. The pattern of hereditary is derived from the maternal side in more than 10 to 15% of patients, and from the father in 3% of the patients. Next. So just after telling about the basics of Downs, what are the genetic tests to diagnose genetic disorders? Broadly, we can say that the genetic disorders can be divided into chromosomal, multifactorial, Mendelian, and mitochondrial disorders. Now here we are concerned more of the chromosomal disorders. So we'll just stick on to the various tests which help in diagnosing a chromosomal disorder. So the first test that can be done is a basic conventional karyotyping, and other specialized tests are the FISH or the fluorescent in situ hybridization. So when we go into the screening test, you can do screening test in newborn, and the antenatal or prenatal screening test can be done, which have been discussed in detail by my previous speakers. So briefly, I will tell you what is karyotyping. So karyotyping is a test which helps to identify any structural or numerical aberrations in the chromosome as such. So normally, where do you get the chromosomes? It is within the nucleus. So any actively dividing cell which contains a nucleus can be the specimen that can be from which karyotyping can be done. So commonly it is a can maybe a bone marrow aspirate or a peripheral blood sample. So what they do is the sample is taken and it is grown in a culture medium. After incubation for 2 to 3 days, a chemical called colchicine is added. So the action of colchicine is that it arrests the cells in metaphase. So as we want only the metaphase where the chromosomes are discretely present, they do not further go beyond the metaphase stage. Then this specimen is then centrifuged and they are seen under a slide after fixing with a gene cell stain. So when they are seen under a photomicroscope, and the picture is subjected to a software where it gets rearranged and you get a karyogram which we interpret. The next diagnostic test for Downs is a fluorescent in situ hybridization. It is a test which detects specific DNA sequence in a chromosome. So here fluorescent tagged probe is added to the sample after denaturation, and after hybridization, they are seen under a microscope. The picture here, it shows the interface fish where you get two different signals with 2 different colors. So because there are 3 chromosomes of 21, you are getting 3 red colors, while the chromosome 13 for probe, which there is only 2. So this suggests this person is suffering from a trisomy 21. The advantage of fish when compared to karyotyping is that the results for karyotyping takes nearly about 15 to 20 days to come, but you can get a fish result within 1 week. So it is helpful in antenatal screening tests. So next we will go to screening tests. So what I mean by a screening test is that it only tells about chances a baby can get for certain medical conditions, but it actually does not tell whether the child can get having Downs. It only tells the risk factor. And these are non-invasive tests. So whenever a screening test shows positive for aneuploidy, it has to be confirmed by a diagnostic test, which are usually invasive tests. So antenatally for a diagnostic test, you do a chorionic villus sampling in the first trimester between 9 to 11 weeks. In the second trimester, you do an amniocentesis between 15 to 20 weeks. And in the last trimester, you can do a percutaneous umbilical cord blood sampling. So these are the various screening tests which can be done antenatally. And I'm not going into the detail because it has been discussed. So this is another screening test which can be done antenatally. It's called as a non-invasive prenatal test. Here, the fetal cell-free DNA in the metal blood is analyzed and the presence of aneuploidies can be identified. This test can be done from 6 weeks of pregnancy itself. But as my previous speaker said, this is also a screening test. So it has to be confirmed by a confirmatory diagnostic test, either by an amniocentesis or chorionic villus sampling. So the next genetic testing, which is gaining importance nowadays, is the pre-implantation genetic testing. Here, the embryo in the pre-implantation stage is tested for any genetic defects. So this is playing an important role in cases of IVF, etc., where there is the potential for the offspring to develop some Mendelian disorders or chromosomal abnormalities. So before the embryo is allowed to grow itself, when it is in the 4 to 6 cell stage, one of the cells is drawn and that is subjected to a fish or a karyotyping by laboratory analysis. So if it is found to be normal, they are allowed to continue with the growth of the embryo. But when it is abnormal, they do not utilize that embryo for this IVF. So this helps in more of prevention of development of any aneuploidies in the child. So with this brief talk about the tests and what are the cytogenetic abnormalities, we'll go to some case scenarios. So these are the case scenarios which all of us come across in our clinical practice. So first one is a 31-year-old female married for the past 1 year, now 2 months pregnant, and has come to the genetic clinic as an ultrasound shows an increased nuclear translucency and a maternal serum test showing an increased risk for trisomy. So next one is a 25-day girl baby brought by the parents as the baby had dysmorphism and was advised by a pediatrician to consult a geneticist. The third scenario is a 2-year-old boy with developmental delay and a ventricular septal defect who was evaluated and the karyotype showed an extra 21 chromosome. Now the parents are anxious to know whether the child can be cured. So now as a clinician, what are you to do? So the ultimate solution for this is a genetic counseling. So now with the going into the preventive aspect of all chromosomal disorders, genetic counseling is gaining importance and it is the order of the day. So what do you mean by genetic counseling? It's a communication process which aims to help individuals, couples and families understand and adapt to the medical, psychosocial, familial and reproductive implications of the genetic contribution to a specific health condition. So this is a picture showing where the parents or the couple with a child with Downs have come to a counselor for counseling, and the karyotype of this child has shown an extra trisomy 21. So what are the steps in genetic counseling? So whenever, even though you are doing a counseling, the first and foremost importance is you have to make an accurate diagnosis. So with the good family history, pedigree analysis, medical history, examination and investigations and diagnosis, you have to first come to a diagnosis. So once you make a diagnosis of that particular disorder, you have to assess the risks of that disease and what will be the condition like, what will be the prognosis, etc. Once all this is analyzed, you then communicate with the couple about the disease, how the disease will go on, what will be the prognosis, is there any modalities of treatment, management, etc. Then you can also discuss with them the risk for developing such things in the next pregnancies. Once all this is counseled and told to the couple in multiple visits, you give the option to finally to the couple to decide of what to do. Here you have to be empathic and not be sympathetic. So once all this is done, the counseling doesn't stop with this. You have to keep them under follow-up and give a genetic support to them frequently. So what are the different types of counseling? So the first and foremost is a premarital counseling, which is not yet still developed in our country. And here the role of premarital counseling is you can do a carrier testing for the couples so that you can find out any Mendelian disorders, which is running the families, so that they can take an informed decision before planning for a marriage and having children. But in the case of a chromosomal disorder, this primary prevention or premarital counseling may not play a role because you cannot diagnose a Downs by doing a carrier testing. So here only a secondary prevention will be playing a role on our counseling only after there is a high risk of having a child with Downs, or you already have a child with Downs where you want to get a counseling for the next pregnancy. So in a counseling, what are the things you have to convey pertaining to a aneuploidy or a Down syndrome? So what are the things you have to tell is, you have to tell the importance of advanced maternal age, which is said to be the strongest epidemiological variable for the prevalence of this disease between the ages of 15 to 45 years. Then when there is a familial aggregation, the risk is more with the age-specific preference, and it increases to about 4.2 per 1,000. Then when there is a DNA analysis of patients with a non-disjunction trisomy, Mostly the extra chromosome is derived from the maternal side, and there is a crossing over of these maternal meiosis, which confers a substantial susceptibility. Finally, this altered distribution of polymorphisms in the genes of like apoprotein, lipoprotein A, MTHFR, and MTFFR, together with the biochemical and epidemiological evidence, suggests an association with impaired folate and homocysteine metabolism. So the next concept is a pre-test and a post-test counseling. So far, I was just telling about the discussions you do during when the couple come to you with a disorder. But here, this is when you are trying to do a genetic test for the couple. So whenever you ask for a genetic test, you have to tell them pre-test what are the things you have to do and why this test is done. So you have to discuss about the benefits and limitations of the genetic testing, explain the possible results, how will it impact in the management, the importance of the testing the affected individual, the cost, insurance. Now also you have to discuss about the legal and social implications. Once the test is done and when the result has come, again you have to review and interpret the results, discuss about the results with the individuals, the other family members, whether they need to be tested, and you have to give a supportive counseling. So now summarizing, going into only the preventive aspects of Downs, these are the key points you have to keep in mind. The first and foremost is for a Mendelian disorder where you can do a carrier testing. For chromosomal disorders, you cannot do a previous carrier testing to find whether the couple will get a trisomy child. Second, only in risk circumstances, a genetic counselor should give counseling regarding the various screening tests and confirmatory tests. Third, whenever the mother is screening test positive, definitely she has to undergo a diagnostic procedure so that she can plan that present pregnancy. Next is there should be an awareness about avoiding reproduction in an advanced maternal age. And last but not the least is an adequate intake of folic acid during pregnancy, which is believed to protect against neural tube defects in babies, may also help to prevent Down syndrome. So I think with this year's theme of with us, not for us, we have to keep these children with an extra chromosome happy and also keep them loved. Thank you for giving me this opportunity.
Thank you, ma'am. It's a very, we have had 3 wonderful sessions and talks, and all of them were highly informative. We had started with the idea of having a treatise on Down syndrome in a concise manner, and we definitely got what we wanted. So our objective of having this program is definitely achieved. There are a couple of, probably not questions themselves, but there are a couple of comments about increasing the awareness of diagnosis about Down syndrome. I think we'll all agree that we are a lot more aware than what we used to be. And the awareness both for diagnosis and for at least, as Madam said, about counseling and being aware of expecting the kind of problems and we can face. Definitely the awareness has definitely gone up, but I would agree with the attendee who has commented that yes, there is a lot more to be done, and we are trying our level best, and there are a lot of guidelines which have come up, and definitely more can be done, and we are trying to be part of it. And I think Dr. Jalil sir has got a few questions to the panelists. Maybe yes, sir.
Thank you, Thiru. All the 3 speakers are excellent, very good information. I will ask one each to each stalwarts. Dr. Pradeep, you mentioned the genetic surprise. It is also a surprise to us when we are dealing. What you exactly wanted to communicate by seeing the genetic surprise?
That means it is not only genotype surprise, it is a phenotype surprise. Of course, for a pediatrician, it is a phenotype surprise. You don't expect a baby with such an abnormality when you go for resuscitation. So because it remains silent, It was silent throughout. It has gone through all the screening also. The screening turned out to be negative because all the screenings are not 100%. So it may escape all the screening, the baby may escape the scan findings, baby may remain silent, and it will come out as a surprise for a pediatrician and the obstetrician. That is what I meant, sir.
I still remember those days when I was reading Achar and OP Guy. It is mentioned in the Down syndrome chapter, the over ripening of the ovum. What exactly it means? Is it still there is a cause for it, or we are now it is going away from that?
Sir, I couldn't get that exact meaning of that, sir. Maybe is it related to the age of the mother, or I don't know. But again, it is clearly explained by ma'am's presentation that how it has happened. So there is no role, no external role for anything else rather than the core genetics part.
And you mentioned about the twins, the DCDA twins and the MCDA.
Yes,
it's
sir.
difficult to diagnose. Why does DCDA, they'll have a separate card, you know?
Yes,
so
sir.
is it technically difficult? That's why you mentioned about that?
No, because all the screening methods depends on the maternal serum markers, sir. The maternal serum markers and the placental markers changes. They are not uniform in twin pregnancies, and validation of these results are little doubtful than in the singleton. So hence in twins, DCDA twins, of course, both are having different genetic material. But again, monochorionic twins, if there are some features, ultrasound features, you test, you're testing one twin itself gives us a diagnosis, or one placenta gives the diagnosis of both. Related to the serum markers, it is difficult comparing to the singleton because all these maternal values can change.
Yes, Dr. Somasundaram sir, I have a couple of babies with comorbidities like diabetes mellitus, sir.
Oh.
I still have that. Yeah, you have not mentioned the apart from the thyroid, the other endo issues like diabetics is also common. So in the screening, we should screen for evidence of diabetic also.
I was going through 2 or 3 papers, sir. So this was from those things. So most of them were mentioning predominantly about thyroid, then they were mentioning about sexual hormones. And probably that will also be a minor component, but I'm not able to locate, so I have not mentioned. So probably I will go.
Their married life, sir. Downs
life. What I learned was they are 50% fertile, but they are prone for miscarriages more commonly, and they can also get their childbirth and lead on a family life also. As I told you that they have the same intimacy and the sexual feelings, and probably the once we are overcome the miscarriages and those things, then probably the things will be good.
One new message for me is the blast cells in the peripheral smear is from the liver, not from the bone marrow, which is a new message to me.
Yes, sir.
Thank you, sir.
Shall I add a point regarding marriage, sir?
Yeah.
Thank you.
Thank you very much. If there are no questions, I think we'll conclude the session for the day. And
regarding marriage, shall I add one point, sir?
Yes, please go ahead.
Regarding the marriage, sir, it is not just the genetic or the reproduction or the recurrence part. It is more related to the responsibility. A person entering into a marriage has to be very, very capable to take care of the whole family. So we evaluate the family, the child, whether they will be able to handle that responsibility before taking such decisions. Reproduction and recurrences, all these things we can take care as medical professionals. But social responsibility is one thing that has to come naturally. If it is possible, only they can enter into it. All these evaluation we will do, sir.
Thank you. Thank you, Dr. Pradeep. I think as I said, we achieved the aim with which we started with. So a special thanks to Dr. Pradeep, Dr. Somasundaram, and another madam.
Thank you, sir.
Thank you, ma'am, for being here and then offering, they're sharing their wisdom and their experience. It's just a bit unfortunate that we could have had a few more, but because this program is sorry, it's available on YouTube. Usually there are a lot more views after the program, and given that it's a weekday in the middle of the practice, probably we have got a slightly less crowd than what we would have expected. But this week is still young, and we have got a lot more programs going. So tomorrow we have got is it tomorrow? No, Friday. Sorry, Friday we have got adolescent health week celebrations, and Saturday we have got our postgraduate clinics, and Sunday we have got the 4C series. So hope to see a lot more of you guys over there. Thank you very much, and let's pledge to treat our children with Down syndrome not as a medical problem, not as a case, but as an individual who can perform very well. Some of, as Sir said, and even some of my children with Down syndrome whom I am following up, they have achieved phenomenal results. Actually, they are almost like any other children. Some of them, even a couple of them, are going to normal schools. So they are a lot more capable than what they think, and we need to support them and help them to achieve their full potential. So I think with that message, let's conclude the evening. Thank you very much, and
Thank you.
see you in the future. Thank you.
Thank you.